صباح الخير welcome للsecond session of this meeting. عنوان السيشن cardio-renal crosstalks in hypertension، والمتحدث الأول الدكتور وليد عمار من طب القاهرة، ويتكلم على chronic kidney disease as important cause of resistant hypertension. يلا وليد.
بسم الله الرحمن الرحيم. طبعا كل شرف لي ان النهارده اكون في المؤتمر ده اللي بيمثل الجمعيه المصريه لامراض القلب برئاسه استاذنا العظيم الدكتور محسن ابراهيم، وبنهني الدكتور محمد سليم طبعا على المؤتمر. هم الحمد لله ان اختاروا لي موضوع فعلا مهم جدا، انا استمتعت في تحضيره وان شاء الله يكون مفيد للجميع. يعني بنتكلم عن a very risky combination when we have a patient with a CKD and at the same time as hypertension is uncontrolled. In this presentation, I'm trying to briefly go through the definitions, the prevalence, the prognosis, therapeutic options, and the future perspectives for treatment of such a very risky combination. المشكلة إن hypertension and chronic kidney disease commonly coexist, and this interrelation between these two diseases is bidirectional. بمعنى persistently elevated blood pressure will accelerate decline of GFR. At the same time, progressive decline of GFR will prevent us from achievement of target blood pressure control. وبالتالي we'll end up with a very risky combination, CKD and uncontrolled hypertension, that magnifies the cardiovascular risk and causes much more higher morbidity and mortality in patients with chronic kidney disease. يعني ايه resistant hypertension? Blood pressure that remains uncontrolled despite use of 3 or more medications أو the use of 4 medications to achieve a blood pressure. لكن الترمينولوجي ده حصل عليه some modifications from American College of Cardiology وحطوا 3 restrictions. لو العيان ده عنده established cardiovascular disease or at high risk 14 years cardiovascular risk, threshold is 130/80 not 140/90. تاني حاجة إن these 3 medications should include full dose of maximally tolerated RAS blockade, calcium channel blocker, and a diuretic. تالت حاجة we should exclude pseudo-resistant hypertension، بمعنى مش معتمدين mainly على الoffice blood pressure، يفضل based على out of office سواء ambulatory أو home based or unattended office blood pressure. To exclude pseudo-resistant hypertension and poor patient compliance, we have to exclude poor compliance as a cause of resistant hypertension. وبالتالي الترم اتغير من resistant hypertension ل apparent treatment resistant hypertension. ايه أهمية ده؟ وايه أهمية using different methods؟ الambulatory blood pressure في advantages كتيرة عن الoffice based. طبعا we can exclude white coat hypertension, masked hypertension or pseudo-resistant hypertension. لكن مش بس كده، we can detect abnormal patterns زي nocturnal hypertension أو abnormal diurnal variation زي non-dipping و reverse dipping. إيه أهمية الحاجات دي؟ الحاجات دي اللي بتظهر في ambulatory blood pressure is more common in patients with chronic kidney disease, and it correlates with the progression and severity of decline of GFR أكتر من office based blood pressure. The same زي ambulatory blood pressure 1 week monitored out monitor home based blood pressure monitoring correlates with decline of GFR أكتر من الأوفيس، وبالتالي الأمبيولاتري أو الهوم based correlate with decline of GFR and the progression of kidney disease أكتر من الأوفيس based blood pressure. وبالتالي احنا عندنا 2 types of resistant hypertension. We have a true and a pseudo resistant hypertension. طيب قد إيه الماجنتيود اوف بروبلم دي؟ لما بصوا في large registries recording حوالي 3 مليون patients، 3 مليون واحد hypertensive treated patients، لكن معظم الترايلز دي كان بيستعمل اوفيس بيزد بلاد بريشر، لقوا البريفالنس اوف تريتمنت ريزيستنت هايبرتنشن كان about 15%. لكن لما خدوا اراوند 12 ترايلز اللي اعتمدوا على الامبيولاتري او هوم بيزد بلاد بريشر مونيتورنج، لقوا لا ان نص العدد تقريبا سودو ريزيستنت 10% سودو ريزيستنت and 10% true resistant hypertension. وبالتالي when we define a resistant hypertension we should measure the blood pressure accurately يفضل بامبيولاتري او هوم بيست. طيب ايه هو بقى الريفراكتوري هايبرتنشن؟ is an extreme but rare phenotype of complete treatment failure defined as blood pressure out of the target goal despite taking 5 or more medications. وحصل modification recently برضه. These 5 medications should include a long-acting thiazide type diuretic زي chlorosalidone and MRA زي السبيرونولاكتون. If the patient took these medications including spironolactone or chlorosalidone in full doses and did not respond, he has a refractory hypertension. The overall refractory hypertension is very rare. في overall hypertensive patients is 0.6%. لكن في العيانين اللي عندهم resistant hypertension about 6%. وبالتالي 6% of patients with resistant hypertension have true refractory hypertension. طيب بالنسبه للعيانين بقى السي كي دي اللي يهمونا النهارده، the prevalence of resistant hypertension is 2 to 3 times among patients with CKD compared with general hypertensive populations. وبالتالي CKD is a very important cause for resistant hypertension. الأهم إن the burden of resistant hypertension goes hand in hand with the decline of GFR and with the progression of albuminuria. يعني عن CKD كل ما GFR قل أو البروتونوريا زادت كل ما ال prevalence of resistant hypertension زاد. Do we have evidence for that? Yes. It's one of the famous trials regarding study. فيها about 10,000 patients معظمهم CKD. زي ما احنا شايفين من الفيجرز كل ما زاد السيفيريتي of decline of GFR لقينا ان ال prevalence of resistant hypertension زاد من 15% for GFR above 60 ل 33% for GFR below 45. At the same time, the prevalence of resistant hypertension زاد from 12% for patients with no proteinuria لحوالي 50% for patients with severe proteinuria. And when we combine both aspects, decline of GFR and the progression of proteinuria in this cross tabulation, the highest risk, about 50% or more of patients with CKD have resistant hypertension when they have significant reduction of GFR and significant proteinuria. Another trial is a chronic renal insufficiency cohort study. فيها more than 3,000 patients with CKD. Treatment resistant hypertension can 22% when we have a GFR above 60 and increased about 40% when GFR decreased from 30 to 60 and it exceeded 50% when we have a GFR below 15 CKD grade 4. مش بس كده, each 5 millimeter decline in GFR was associated with 14% higher odds for treatment resistant hypertension and again in the same study severe proteinuria was associated with a higher likelihood of treatment resistant hypertension. ايه اهميه ده؟ prospective trials زي اللي قلناها regardless والchronic renal insufficiency وروا ان this combination is associated with increased risk of cardiovascular events. على سبيل المثال في regardless study the risk of development of end-stage kidney disease over 6 years follow-up was 6 times higher in patients with resistant hypertension compared to controlled hypertension. في ال chronic renal insufficiency cohort study, patients with resistant hypertension عندهم about 50% higher risk of adverse cardiovascular events, 28% higher risk of end-stage renal disease or doubling of baseline creatinine, and 24% higher risk of all-cause mortality. يعني مش بس the combination of CKD and the apparent resistant hypertension much more increase of cardiovascular mortality, renal failure, and all cardiovascular endpoints. That treatment according across all the guidelines for resistant hypertension سواء American, European, International Society of Hypertension or KDIGO هنلاقي طبعا البيزلاين ثيرابي هو combination of RAS blockade, calcium channel blocker, then a diuretic. لكن الأهم إن الفورث لاين ثيرابي في كل trials unanimously is spironolactone. When we have resistant hypertension مش نافع مع حاجة هنديله spironolactone. ليه الراشونال اوف spironolactone هو الفورث لاين ثيرابي across all the guidelines؟ البرايمري aldosteronism اللي هي autonomous renin independent release of mineralocorticoid patients with resistant hypertension and hypokalemia. يبدو ان في underestimation للtrue prevalence of hyperaldosteronism وان السبيكترم بتاعها مش كله resistant hypertension وهايبوكاليميا. في انواع منها mildly suppressible او non suppressible او renin independent. طيب الدليل جه منين؟ ان عيانين اللي عندهم ريزيستنت هايبرتنشن لو ما عندهم هاي سولت انتيك المفروض يحصل سبريشن للرينين. اتضح ان نصهم تقريبا despite that الالدوستيرون excretion is excessive، وبالتالي these patients may have some form of autonomous release of mineralocorticoids which is not suppressible by high salt intake. السبيرونولاكتون في trials was very successful in reducing blood pressure. It decreased systolic blood pressure by about 22%, 22 millimeter mercury, and diastolic blood pressure by about 10 millimeter mercury. الجايد لاينز زي ما قلنا كلها بتسبورت سبيرونولاكتون، لكن اهم ترايل وضحت اهميه السبيرونولاكتون في resistant hypertension هي الباس واي 2. This trial excluded patients with advanced kidney disease سواء كلاس 2B او كلاس 4 CKD. والامريكان واليوروبيان جايد لاينز ريكومندد سبيرونولاكتون لكن لازم الجي اف ار يكون اكتر من 45 والبيز لاين بوتاسيوم اقل من 4.5. وبالتالي الراشونال بتاع الجايد لاينز in avoiding use of spironolactone in advanced kidney disease هو الفير اوف hyperkalemia. هل ده فعلا موجود في الحقيقه؟ This is a big registry فيها 17 trial 34,000 patients with low GFR اقل من 60. اليوز اوف سبيرونولاكتون in real life كان من 1 to 9%. وبالتالي في الحالات دي اللي عندها resistant hypertension وهتستفاد قوي من السبيرونولاكتون الريت اوف prescription was very low because of fear of hyperkalemia. This is a meta-analysis لترايلز كتيرة فيها CKD large proportion of patients. When we add spironolactone فعلا the risk of hyperkalemia increased by 2.6 folds compared with no spironolactone. يعني فعلا spironolactone can cause hyperkalemia in patients with CKD which is the main limitation. في حل نقدر نقلل بيه ال risk of hyperkalemia not to prevent using this very valuable medication is to add a new potassium binder like this trial, Ammar trial. Patients with CKD at risk of hyperkalemia, resistant hypertension, we give them spironolactone, but we give them at the same time potassium bind batriumir. In this trial, about 300 patients not tolerating or not responding to 3 antihypertensive medications with GFR from 25 to 45. At the end of the study, 86% of patients in the potassium binder group tolerated spironolactone compared to 6% in patients not on potassium binder. بالتالي we have a new therapeutic modality that we can add to spironolactone to prevent hyperkalemia in such patients. Another option, if the patient has hyperkalemia, cannot tolerate spironolactone, the other one could be a long-acting thiazide-like diuretic chlorosylidone. In chlorosylidone in chronic kidney disease patient trial, 160 patients with stage 4 CKD uncontrolled hypertension received chlorosylidone starting dose 12.5. At the end of the trial, these patients achieved a good reduction of systolic blood pressure by 14 millimeter mercury, and of course there is no risk of hyperkalemia with chlorosylidone being a thiazide diuretic. وبالتالي it's another treatment options. What about the future opportunities for pharmacotherapy for resistant hypertension? Non-steroidal MRA like osidirenone in a good trial, aldosterone synthase inhibitor, baxdrostat in Brighton trial, and finally dual endothelin receptor antagonist aprocitentan in a precision trial. All these medications achieved a good reduction in systolic blood pressure. However, it's too early to prescribe these medications. They are under experimental assessment. Renal denervation. The rationale for renal denervation is that patients with CKD have highlighted or increased sympathetic activity, and it may be plausible to abort this increased sympathetic activity. However, the use of renal denervation decreased after the neutral results of the Simplicity trials in 2015. However, we have 2 years ago publication of long-term efficacy, safety, and tolerability of this procedure in patients who were not responding adequately to treatment medications. We have some reduction in systolic and diastolic blood pressure, about 10/6 millimeter mercury. However, for the right now, we cannot recommend renal denervation therapy. Instead, we need more well-conducted sham-controlled trials to assess the feasibility, safety, and efficacy of renal denervation therapy. All these medications are important, but the literature also recommends that good salt restriction is very important in all hypertensive patients, especially in patients with CKD. And they recommended a daily intake of below 90 millimoles per day. In conclusions, Mr. Chairman, The burden of resistant hypertension in CKD goes hand in hand with the decline in GFR as well as in severity of albuminuria, very important. In such patients, the addition of spironolactone to baseline antihypertensive regimen is the treatment of a choice. If we don't deal with hyperkalemia, thiazide-like diuretic chlorosylidone may be an alternative therapeutic option in this high-risk patients. And thank you very much.
شكرا كتر خيرك. This was very excellent review. And I have a question or a comment regarding patients with resistant hypertension. The introduction of the aldactone, of course, is important, but in spite of the aldactone, still the patient is hypertensive. So my policy is to be more aggressive with diuretics in patients with renal insufficiency. I would go more for loop diuretics in increasing dosages. If still the patient is not controlled, then I will think of vasodilators. You didn't refer to the use of vasodilators in the management of these patients. It is really a problem facing patients with resistant hypertension. Sometimes we look to the heart rate. If the heart rate is rapid, we have to go for more of the beta blockers. Thank you. You covered the topic very well.
Thank you, Professor Waleed. It's always our pleasure to have you with us. And I think this session is very important for us as a cardiologist. This is why you started, and then the professors of nephrology and internal medicine. I have a small question for you and a small comment regarding the MRA, the prototype or the old one is the spironolactone. The same is applied for the newer one, finerenone and eplerenone. It's the same, but they are lacking evidence, I think, in resistant hypertension. What do you think about this?
زي ما حضرتك بتقول صح، كل الترايلز اللي اتبنى عليها ريكومنديشنز بيزد على سبيرونلاكتون، واشهرهم هي الباس واي 2 ترايل دي. ابليرينون ذا سيم، اولموست ذا سيم زي السبيرونلاكتون، انما الفينيرينون ده ديفرنت، ده نون سترويدال ام ار اي، ده مختلف. والايفيدنس كله في البروتونوريا في الدايابيتيك بيشنتس، انما في الريزيستنت هايبرتنشن ما عندناش اي ايفيدنس ليه، زيه زي الاس جي فور اكزامبل، اس جي ال فدول اكسكلودد. انما الابليرينون ديسبايت اللي ما عندوش، لكن هو ذا سيم فارماكاينيتيك بروبرتيز with less side effects عن السبيرونلاكتون.
So we can use it.
Maybe yes.
Okay. Regarding renal denervation, this is my comment. هو بس renal denervation ان كل الترايلز بتاعتها كانت excluding البيشنت الجي اف ار اقل من 40. في ترايلز ongoing ممكن تقول غير كده.
في two small trials على العينين دول، واحده منهم وردت انه بيقلل البروتونوريا كمان، لكن two small trials.
تمام.
Professor Waleed, thank you very much. Excellent as usual. My question is about, is there any role for SGLT2 inhibitors in this area of resistant hypertension and chronic kidney disease?
We know from our trials for SCG that hypotensive effect is minimal for SGLT2 inhibitors. And we don't have any trial right now for using SCG in patients with resistant hypertension. We don't have any evidence for that.
تفضل حضرتك.
Thank you very much for this very elegant presentation, and many points of my question has been answered by the chairpersons already. Actually, the MRAs should be a very initial management in patients with CKD. It should not be left to only resistant cases, and when you have resistance, you should include them as one of the 4 main pillars of treatment of CKD, particularly if they are hypertensive, including the SGLT2 inhibitors and including the sodium bicarbonate, and both of them, sodium bicarbonate and SGLT2 inhibitors, will prevent from the occurrence of hyperkalemia. So the use of MRAs, whether spironolactone, eplerenone, or the recent non-steroidal finerenone, will give an advantage of the patient to manage the CKD, control of the blood pressure, and limit very much the occurrence of hyperkalemia. And as you mentioned, we should not refrain from using them, particularly if we have the weapon of the potassium binders. So sodium bicarbonate, SGLT2 inhibitors as well as the potassium binders should encourage us to include the MRAs as a very initial treatment and not be left to the end weapons.
تمام دكتور جمال. That's why such patients should be managed by cooperative work between cardiologist and nephrologist.
احنا مش متأخرين يا باشا.
لاست كويستشن بس عشان الوقت اتفضل.
هو بالنسبه لمعظم الكومباينيشنز اللي عندنا كلها سايزايد، وحضرتك عارف ان السايزايد شورت اكتنج، فيعني تقريبا انما الكلورساليدون مش موجود خالص او موجود مع اللي هي البيتا بلوكر، لكن معظم ادويتنا فيها سايزايد وفعلا مش بيغطي اليوم وتقريبا بيبقى يوزلس يعني كانتي هايبرتنشن.
والافيكاسي اوف شورت اكتنج سايزايد از نوت فيري هاي ان بيشنتس وذ ادفانسد كدني ديزيز. حضرتك معاك حق، وبالتالي
يعني
ممكن
بنستخدمهم لحد جي اف ار فوق 30 بس. يعني انا قصدي حتى في الهايبرتنشن عامه في، لكن احنا بنستخدم الاندابامايد او الكلورساليدون اللي هم المفروض هم دول
عشان كده الدكتور محسن قال بيفضل اللوب دايوريتكس في العينين دول.
لا مش
تمام.
Yes, okay. الاندوبامايد is a long acting.
ما انا بقول كلورساليدون واندابامايد
تقدر تستخدمه. شكرا يا وليد. But you didn't refer to the use of alpha methyl dopa aldomate in these patients at all.
We respect يا دكتور محسن الميديكيشنز اللي عندها evidence of benefit regarding cardiovascular endpoints. ده مش موجود قوي للالدومات او الالفا ميثايل دوبا. طبعا اهم تريتمنت هنا هو الراس بلوكيد سواء ايس انهبيتورز او اي ار بيز، ثم فاز دايليتور كالسيوم شانل بلوكر ميلي املودوبين دايهيدروبيريدينز، ثم الدايوريتكس. طبعا لو احنا كل ده نوت ريسبوندنج خلاص هندخلنا بقى في الريفراكتوري. هنا في عندنا سبيرون لاكتون كلوروسايلاميد الفا ميثايل دوبا الفا بلوكرز بيتا بلوكرز، لكن I think there is no contraindication for the three main pillars. We have to start with them from the beginning. شكرا.